So let me tell you a story, I guess, about how I became interested in this area and why I believe that it's something that we really should be doing better in. So it started with this lady, who I'm very proud to call my friend, Kate Swaffer. And at the WHO Ministerial Conference of Dementia, she said that people with dementia wanted three things. That people with dementia said that they're a human right to a more ethical pathway of care. So this is different from an evidence-based right. This is a human right, which is kind of an interesting way of thinking about services, not a way that I was trained in thinking. She said that people with dementia have a human right to be treated in the same way as everyone else, which suggests that we don't treat people with dementia in the same way. And that research does not only focus on cure, but on pre- and post-diagnostic care and on rehabilitation. And I'm like, what? Can we rehabilitate people with dementia? That doesn't make any sense. We don't do that. We're trying to cure people. I've been doing all this research on prevention and cure. What's this rehab stuff? And this was listened to and was taken up, for example, by the WHO Global Action Plan, which as one of the points says to promote community-based rehabilitation as a strategy to enable and support people with dementia in preserving their autonomy and rights and ensuring that people with dementia remain in the centre of all discussions on diagnosis, treatment and care. And the WHO definition of rehabilitation is very broad, and that's the one that I'm using and we've been using in our work. So it's a set of measures that assist individuals who experience or are likely to experience disability. So basically, all people with dementia have a disability. That's the definition of a diagnosis of dementia. And I will put people with MCI, mild cognitive impairment, in that they're likely to experience disability, to achieve and maintain optimum functioning in interaction with their environments. And optimum functioning isn't just medical or health functioning, it's daily functioning, it's social functioning. I just want to contrast, I guess, that definition to this very common model of Alzheimer's disease that I see about 20 times at each big dementia conference that I go to. Because I guess it shows the focus of the research that I was doing and that most people do in dementia. With a shift, I guess, with you know, a very biomedical way of thinking about it, where we're looking at brains and biomarkers, and a big shift, I guess, in the last 20 years towards prevention research, delaying research, and care research. So they're the three streams of research. And rehab kind of sits there in my mind. There is thinking around non-biomedical models of dementia. I've just put some examples there. Thinking about dementia as a social experience, so not just an experience of biomedical symptoms, memory loss, but of a condition that changes how you interact with the world and the world interacts with you. And let's just talk then about human rights. And this is the new second edition, the new edition of the Australian Charter of Human Rights, which is based on the international human rights stuff, but I've just given you the Australian stuff, which says, I have a right to access healthcare services and treatment that meets my needs. So do we do that for people with dementia? I have a right to safety, receive safe and high quality healthcare that meets national standards and be cared for in an environment that's safe and makes me feel safe. Do we do that for people with dementia? I have a right to be respected, to be treated as an individual and with dignity and respect, and have my culture, identity, beliefs and choices recognised and respected. Do we do that with people with dementia? And I have a right to information. There's a whole lot of them. I just put the first one there. Clear information about my condition, the possible benefits and risks of different tests and treatments, so I can give my informed consent. And next series of slides, I'm going to show you how we consistently don't meet these rights. This is not all Australian literature, but the same would apply here in Australia. So, we know that post-diagnostic support's almost non-existent in Australia. Rehabilitation is rare, and there's less chance of getting rehab under conditions. So Terry Pratchett wrote about this a long time ago. He said, I remember that on that day of rage, thinking that if I'd been diagnosed with cancer of any kind, at least there would have opened in front of me a trodden path. There would have been specialist examinations. There would, in short, be some machinery in place. I was not in the mood for a response that said more or less, go away and come back in 6 years. I was at one stage working in the Prince of Wales team, which had a memory clinic, and that's what we kind of did. Not as horribly as that, but we gave people the diagnosis, we gave them some information, we referred them to the local Alzheimer's chapter, or now Dementia Australia. We might have suggested vitamin E in those days, and we've changed those guidelines. Maybe we used to suggest ginkgo. We gave them a cholinesterase inhibitor, it was possible, and that was it. And then we say, come back and we'll tell you if you've got worse in 6 months or 1 year. Kate wrote that she was told that it was worse than neglect, that she was actually told to give up work, give up study, and get her end-of-life affairs in order and get acquainted with aged care. So her neurologist suggested that she should be cutting back because, it was getting hard for her to manage. So this resulted in her, and she says other people with dementia, giving up hope, losing self-esteem and self-identity, becoming increasingly isolated, taking on a sick role, so learned helplessness basically, and withdrawing from potentially beneficial activities. And if you know Kate's story at all now, you know that since she got diagnosed, she has done a master's and she's enrolled in a PhD. She's kind of terrifying in her travel schedule, which is much more rigorous than probably any of us here, and she really manages to do a lot, even though she's got dementia. And she does have dementia. I'm friends with her, and she won't mind me telling you that we took her home the other day to a hotel. She's staying at the city, and she told us the wrong hotel. We drove around for ages before we had to check her hotel keys. And we went, oh, you're not staying at the Stamford on the Rocks, you're staying at the Four Seasons. So, she does live with a disability, but she somehow manages. So we ran a systematic review of qualitative studies of the experiences of people living with dementia, and we found that people were dissatisfied with how the diagnosis was given and the information provided, and that most people got very little treatment. Medication being the most common, and if you got medication, you got some hope along with it often, but they very rarely were the social health of participants talked to, and almost in none of these studies did people talk about professional help with their memory, function, or communication. Those are the symptoms that people live with that are troublesome to them. So what do we have here in Australia now? Well, Dementia Australia runs a Living with Memory Loss program. It's for dyads, so it's for the person with dementia and their care partner. They're usually face-to-face sessions, so if you don't have a care partner or you can't make it to when they run those groups, you don't have access to them. So it serves, I've heard really good things about this program. I'm not dissing it, I'm just saying that we don't have universal access. There's also some care navigator trials happening around Australia, which is helping people to access services. We're not giving more services, we're just helping people get them because it's hard to get them. This one slide is showing that people with dementia are less likely to get rehab. This example is stroke rehab, but there's other studies showing, hip fracture rehab and stuff. So this study of 112 hospitals found that if you had dementia, you had lower odds of receiving acute goal-directed treatment or post-acute rehab as well. So people with dementia are discriminated against. There's a hospital here in Sydney, which I shall not name, which has a mini-mental cutoff for getting rehab. So if you're below that mini-mental score, you can't get rehab, essentially. This is despite, and I haven't got the slide here, pretty good evidence that people with dementia do benefit from rehab. Sometimes it takes a bit longer and the gains might be smaller, but they still do improve. And when I say rehab here, I mean like the post-acute illness rehab. So there isn't actually much written asking people what they want post-diagnosis. I've been to a few roundtables now where people are talking about it, but we don't have much literature. So I've just flagging, I guess, this UK report that says that people with dementia want information and advice, and then they want formal support, including medications, early intervention, counselling, education support, rehab. I didn't add that there, that's in the report, including improved physical and mental health, and I've put in my brackets, and maybe daily and social function help and use of technology, because that's what some people with dementia are talking to me about, and peer support. They also want day programs and respite services for carers. So I'm not going to labour this point, but we have seen lots of evidence that people with dementia aren't safe when we care for them. That's Oakden, Four Corners, and there's a whole Royal Commission into this. So, but we don't do this well enough. So let me tell you, I guess, my personal experience about listening to people with dementia and how it's challenged my career. So this paper, which I, as a much junior researcher, wrote with Henry Brodati and Brian Draper, has been very popular. Brian describes it as having wheels of its own, because basically the federal government has used it to fund dementia BPSD services. So I guess my early career was about as a BPSD researcher. But Kate and other people were like, have been running this Ban BPSD campaign. So it's something that I'm famous for, right? I've got a thing about, and they want to ban this term. They don't like it. And they're saying it's not a good concept, that it medicalises dementia, that the behaviours are not behaviours of concern or even symptoms of dementia, that they actually happen because it's a response to the way that they're treated or cared for or the environment. And while Kate and I have had arguments where I go, well, sometimes it's to do with the brain. She goes, well, yes, maybe sometimes it's to do with the brain, but most of the time it's not, which is probably accurate. That this term is not helpful. So, Con Cunningham and Henry put out this paper in response to this campaign, which kind of says, but we still like the term BPSD, but we're hearing you. And I think that's really interesting that we have this shift in language and power. And my own, I guess, personal struggle about what to do when people with dementia speak out, and it's not great for my career, but actually I see their point, and maybe I should be listening to them. And how do I manage that ethical difficulty? And I've decided that I'm okay with the term BPSD. See, this is my own personal thing. I'm okay with the term BPSD for research purposes, but I would never call it that if I was working in a facility or with aged care with people with dementia. And I say to Kate, just tell me what you want me to call it, and I'll call it that instead. But she hasn't decided yet, which is problematic, because it would be easier to push for something else if it was clear what the term is. But I think that's why it's so fraught with difficulty. Some people with dementia like the term responsive behaviours, but Kate was like, I hate that, don't call it that. So I'm still stuck. But I guess it's that really people with dementia have a much stronger voice in the research we do now, and I think it's our responsibility to listen to them. So this review is about people with dementia not being routinely told their diagnosis. So we did a review on how medical practitioners communicated their diagnosis, and our pooled data showed that 34% of GPs and 48% of specialists routinely are usually told their person their diagnosis. It's pretty dreadful, isn't it? And then that rate was much higher for families. I can't go into the details of why that is, but this is the qual side of that paper, which is a mixed methods review, and it basically shows that people aren't told their diagnosis for a complex set of reasons. So it's not just what the practitioner thinks about dementia and whether there's treatment and how confident how confident they are in the diagnosis, how they can talk to the person, how they can manage the person, those things are important. It's also about the person themselves, so how aware they are of the symptoms, whether the family, drag them into it, whether the person's saying, I don't want to know, don't tell me. And sometimes, if families say don't tell them, doctors won't tell them. It's to do with the health and social care system. So doctors would say things like, well, there's no point in telling them because they can't get any services where I live anyway, or where we live anyway. And also the point that it takes time to manage dementia, and I don't get paid. It's really hard to get paid enough money to do this. And then I guess the bigger picture was that there's a lot of stigma in the community, and doctors were saying it would really upset them to know they had dementia, and I don't want to upset them. I don't want to make them depressed. And that's just how I was taught to do it. That's how we do things. We don't do things this way. We do things this way. It's quite interesting. So knowing the work you guys do here, I'm going to kind of talk about complex systems and how, GP training alone probably isn't going to fix this problem. So I was trained as an evidence-based medicine practitioner, and it's challenged me, I think, the idea that we might not have enough evidence to give people rehab, but they have a right to it and we should be doing it anyway. But when you look at the evidence, actually there is some evidence that we should be doing rehab for people with dementia. So this is lots of forest plots coming up in this next section. So a review showing that a pooled effect size of 0.65, favouring exercise for cognition and dementia. It's about 3 days a week of exercise of moderate intensity for about 12 weeks. We always seem to do standard 12-week things. Well, it looks like that. 3 days a week for 12 weeks exercise. Looks a lot like guidelines for exercise, basically, moderate intensity. This pooled analysis doesn't meet significance, but I know that there's a lot of interest in resistance training and cognition as well, and my colleague at the University of Sydney, Maria Fioratoni-Singh, is very keen on this, so she thinks, though the pooled evidence isn't showing it yet, that resistance training is an important part of improving cognition as well. Hot off the press, Alex Baha-Fuchs, who some of you would know, his Cochrane review showing very similar pooled effect size of 0.65 when you look at cognitive training versus controls on cognition. It also delays progression, but there's no overall impact on daily function. This is quite an old review now, but the newer studies have been consistent, showing that cognitive stimulation therapy improves cognition with a pooled effect size of 0.37, with also consistent pooled analyses for showing overall improvement on quality of life and care well-being. Some of you are going, well, what's cognitive stimulation therapy? I don't even know what that is. So these are little groups, nice groups of enjoyable activities which provide general stimulation for thinking. So the discussion groups, we play games, we might talk about the newspaper, we have fun, we do some maths, we might play bowls. They're kind of cognitively stimulating groups where we get people to hang out and talk together, essentially. They have published a at-home program which didn't show improvements in cognition, where you just did the care around the program. So CST has been in the guidelines, in the NICE guidelines for dementia in the UK for quite a few years now, but it's so rare to see this program run in Australia. These are meta-analyses looking at psychological treatments. So any type of psychological treatment, group CBT, supportive counselling, IPT for depression, showing that there's fewer studies, but consistently showing that we can improve depression and anxiety in dementia. That's anxiety again. And this series is showing that occupational therapy interventions also improve daily function, quality of life in dementia. So there's a suite of... Oh, I just want to draw your attention to this new study that came out, the great study published by Linda Clare this year, which is called cognitive rehab, but if you talk to Linda, it looks a lot like occupational therapy intervention. It's a a daily goal a goals for treatment type of intervention, structured intervention, 10 sessions for 3 months, where they improve goals as well, functional goals. So, based on NHMRC grades, there is actually evidence, pretty good evidence, for exercise, CST and cognitive training, and grade 1 evidence, the fewer studies on psychological treatments in OT. But we don't provide any of these for people with dementia. Just to flag that we have a book that Kate Lever and I are editing now, which will summarise all this evidence, hopefully, with lots of Australian and international contributors. So this leads me to this gap that you know about that's dreadful, and, well, we've got this evidence, but no one believes that there's evidence. Doctors still think we can't do anything, and then no one's doing anything about it. And here are some examples of things that projects that I've been involved in that are trying to, I guess, implement some interventions. So this is headed by my boss, I would call it my boss, Lindy Clemson, in conjunction with Kate Lever at Flinders. So this takes Laura Gitlin's trial, COPE, and which had improvements in a trial setting, so in a university setting, and implements it in Australia. So COPE is basically OT sessions plus a few nursing sessions, essentially, in the community. Up to 10 sessions per patient, caregiver dyad, where we upskill carers. We worked with 17 organisations and providers around Australia, and we got them to do COPE. We didn't give them money to do COPE. We gave them free training, but we didn't pay for the sessions. The whole point was for them to find out whether it can be implemented within the existing settings. So can they charge money? How can they charge money for this to happen? And can they get the same outcomes as we got in the trial? So we worked with health services, aged care providers, and some private practitioners. The study is really interested in implementation and how it was implemented much more than are we getting the same outcomes as Laura's study. So we show that, so these are unpublished, but thank you for Lindy for these slides. We show that when you talk to the occupational therapists, that they feel that they understand the program and are confident in delivering the program. Step 1, training worked out okay. They also were inspired, they had intention to deliver the program. But we know that I intend to lose weight at the 1st of January every year, and it doesn't always happen. So we asked them to complete at least 3 programs after we trained them. And 18 of those did that or more, 9 didn't, and 11 people we trained didn't do any programs at all. So it's kind of what you would expect in an implementation study. This is not pure research. We didn't give them any money to do this. We just gave them some free training and said, go for it, and then nagged. But I think that we were pretty happy with that, actually, because we got probably like 2/3 of people doing something. And then in the 84 clients that we got data from, so we didn't collect this data ourselves, we had to get the practitioners to collect this data for us. We found that carers said that they improved significantly in their ability to understand the person's behaviour and to manage day-to-day caregiving. And they also improved in their ability to handle new problems. So those were things that we were targeting in the training, in the program. We also found that the people with dementia were more engaged when doing activities alone or taking part in activities they used to enjoy. So we found that we could implement COPE in government, NGOs, and private practitioners. This is very exciting, and we kind of know the funding models that they used to fund it. So some of them were funded through CHSPs, some we were funding through those allied health visits, some were funded through TransPACs or hospital-to-home programs. It was really interesting how we managed to get these. We got outcomes for the person with dementia and carer, and now Kate Laver and Sally Day are trying to figure out how to keep this sustainable. Now we've run out of research money in terms of trying to get COPE everywhere. And we have a website if you're interested. So go and look at it. The other program, which is also in the OT nursing space that we're working on, is led by Yoon-hee John, the pilot. And it started off as a program based on Capable, led by Sarah Scanton. This was a program where they did OT, some home mods, and a bit of nursing for people without dementia, but of low SES. And we brought it to Australia. Yoon-hee brought it to Australia. She was really excited. And we piloted it for people with dementia and discovered we had to do it quite differently when they had dementia. We didn't have the low SES problems in our pilot area. And so we didn't end up calling it Capable. We called it AIHI. And we're halfway through this study now. So it's a multi-centre, pragmatic, parallel arm stratified RCT and implementation study, and I don't really understand what that means, but we did publish a paper. But basically what we're doing is we're trying to get AIHI implemented by health and aged care organisations. We are giving them some money to do it, and we are asking them to stick to the protocol very strictly, in the way that in COPE it was much more flexible. In COPE we said, try and do 10 sessions. I'm just showing you that data. Try and do 10 sessions, try and do a minimum of 5, but if you do less, better nothing. And we've got some of that data that we're analysing, whereas in this it's much stricter still. But we're interested in whether AIHI makes a difference to self-care, so function being the primary outcome, and then we're interested in implementation. And I think it's really interesting that rather than running a straight university study of AIHI, that we've tried to do it this way in implementation. And I think that we'll learn a lot more from this study than we just run it out of our university. So AIHI is a 4-month interdisciplinary model of care integrated in community aged care and hospital aged care services. 12 visits, some from an OT, some from a nurse, plus allied health depending what they needed. Also very important is case conferencing and kind of teamwork, so interdisciplinary work. We have no results, but I can tell you the problems we're having. So staff time and availability problem. Even though we're paying, we're paying money for the OTs and nurses to do it. We can't get the OTs and nurses to do it. It's really challenging. Staff turnover, people get pregnant, they go on leave, they go on holidays, they leave, and then we're like, well, now we've trained this OT in this organisation, they've gone. Or the manager leaves, which is even worse. And then this interdisciplinary work habits is quite interesting. So in one organisation, the OTs and nurses are in separate teams, and they don't talk to each other, and they still don't talk to each other for intervention. So we have to force them to talk to each other in the case conferences, which Yoon-hee, bless her heart, goes to like all of them, or as many of them as she can. So it's really challenging, I think, like the way that the teams are set up. And then I guess the other interesting problem that we're having is eligibility. So we know there's heaps of people with dementia out there, right, who are getting services. I've told you that. But lots of them don't have a formal diagnosis of dementia. And we don't have Australian data on this, but we know from kind of international studies that we think that 50 to 60% of people in the community don't have formal diagnoses, and that's the problem we're running up against here. And we're just about to change our criteria so they don't have to have a formal diagnosis, because so few of them do. The other eligibility issue is that family carer able and willing to participate in the study. So it's a lot of sessions that we will need the carer to be in, and they have to be engaged. They have to be living close to the person and have a certain number of hours of contact a week. And we're finding that lots of carers are like, well, I live in Brisbane, not in Sydney, or I don't see them enough, or I have a job and I can't do this for this person, which I guess is this challenge if I'm interested in in giving rehab to people with dementia, about how to provide services for people with dementia in these circumstances, and this assumption that we've had, and I think in some of our service models, that everyone has a carer who lives with them or very close by and can somehow provide these additional supports. And now that we're excluding a whole bunch of people from our studies because of this, how do I solve that problem? I don't know, that's just a question. I'm going to tell you about this very tiny pilot study that we're doing, which is called the Dementia Lifestyle Coach, which is a post-diagnostic support program for people with dementia. So to participate, you have to be diagnosed with any type of dementia in the last month and able to participate in the program, which is very broad. And we've got 12, maybe 11, maybe we've got 12 participants now, and that's just a demonstration project. So we're offering 14 hours of coaching and counselling in a semi-structured program where the person sets goals based on values to live well. So some of Linda Clare's work about adjusting to the diagnosis, managing feelings, encouraging people to stay active physically, mentally and socially. So I was trying to get some of that rehab elements through there in a tailored way, so help them find their local exercise group and do what they're normally doing. We also have included a peer supporter, and I showed you some pictures of our peer supporters there, so that someone who's living with dementia now, who we pay a small, tiny amount of money, I pay them to have up to 6 hours of conversations. They're a mixture of by phone, Zoom, or face-to-face, and the coach and counsellor is not there. We debrief the peer supporter afterwards, and we pre-brief them beforehand, but we're not there. So it's a conversation between two people with dementia. And they're structured, and they're meant to provide emotional support, practical support, information support, practical tips, and I think most importantly, appraisal supports. So in these conversations, it's really interesting that the participant with dementia might use the word dementia for the first time, much more likely with our peer supporters than with us, the counsellors. And they meet someone living with dementia who's okay and doing fine, and it's just a normal person. And it's really interesting, I think, how those relationships are built. And some have been more successful than others, but we certainly can offer this as a service. So that's work in progress, and we just show that we can do this now. I want to share something that's another pilot study, but that's finished. And it's set in nursing homes. What am I doing? All right. So we know that person-centered care improves a whole bunch of outcomes in dementia. And we know that people don't do it. I was sick of running intervention studies in nursing homes where we went in, we delivered the intervention, we improved outcomes, we left, and then it stopped. It's really sad to do that. And I've told the story about how we set up a whole not-for-profit to try and deliver services, and that's untenable, and there must be a better way. So this study was an attempt, to figure out how to do culture change in nursing homes within the nursing home, not from outside, from within the nursing home. So the intervention includes leadership, supporting the leaders, training staff on a whole bunch of dementia stuff, training the lifestyle officers about how to be lifestyle leaders, not just run activities. This is quite a different way of thinking. Training the nurses to be clinical leaders and really pull things up, and then some procedural changes, which I'll talk to you about. And we were trying to get short-term change in terms of engagement and activities, and longer-term outcomes in terms of quality of life. So here's some of the procedural change that we did. These were hard to do. So residents normally get, I can't remember, I showered by 20 different people a week or something. It's really bad. So we wanted to change the way that facilities rostered so that each small wing or area had the same carers each time. It's quite interesting. Kind of seems intuitive. People do it mental health and stuff, but facilities found this really challenging. Well, no one wants to work in that dementia-specific area. No one wants to live in the heavy lifting area. We've got to change. And then one facility, which we rotate people so they don't get too attached. So it kind of sounds like a no-brainer idea, but actually it was not a no-brainer idea. So we had to roster people in areas, and And that made it hard. And management found it hard in terms of holidays and sick leaves and personality as well. So that was fun. But we can do it. And then each resident was allocated a focus carer or buddy or whatever it is you want to call it. Each place call it differently. So that was anyone in the facility. Could be someone in the kitchen, could be someone behind the office, could be a handyman. And we really encouraged the directors of nursing or the managers to to be a buddy as well. So they were to get to know the resident well and develop a relationship, to get to know and work with the families, to take a lead in focusing on the residents' well-being, quality of life, and to act as a spokesperson to residents' well-being, including where we managed to do it, that they would sit on CLARPAN reviews and stuff like that. So they had to complete a personalised life history for the person, shared it around. In some places we put them up and had people guess who it is. We played all kinds of games. We gave prizes, all kinds of fun stuff to get this to work. And then once we had the focused resident kind of happening for 3 to 6 months, we put in focused residents of the week or best weeks. So we had a roster so that every week the team would focus on one, or depending how big the team was, a couple of residents and give them their best week. So we're going to share information about that resident because we're talking about them. We're going to try and give them the best week. We're going to figure out what they want, put that into the care plan, and then, make this thing happen. I'll show you an example in a minute of that. I've got lots of lovely stories of that now. But to show, I guess, even in this small pilot study in 3 sites that we improved the residents' perceptions of safety, occupational engagement, dignity, and total quality of life on the ASCOT, improved depression and function. So here's a best week story. Doris, she loved horses. She met her husband in the jockey club, and she had pretty severe dementia at this stage. She loved horses. So they got her a horse. It's pretty obvious, right? That's all she talked about that time in her life. So we have lots of little stories like this where they're beautiful. We've got beautiful pictures of people on the beach in wheelchairs, people in wheelchairs fishing, people going to the movies. What a normal thing to do with their best friend. The fun things are like when they go to the footy, people going out and doing stuff. Some people want to host things, so we host date nights where they have their husband, they have a romantic dinner, just the 2 of them somewhere in the facility. Then yes, a horse might be more difficult, but but not that hard. And I just want to tell you a story, I guess, from Whidden, because one of the things that they did was that they always did stuff for the local show, one of the regional centres. So they had chickens that they entered in the show and they made jams. And last year there was a lot of rain out in the country and the showground was rained out. So they hosted the show in their facility, which is amazing. So they had the show in their facility because they had the space. So I think that's kind of growing out of, trying to make sure the residents have a great life. So Whidden Group, we did a pilot in two of their sites. They loved it. Vicky, who we hired as a trainer, rolled it out to all 18 of the facilities, and they won a big prize last year. And I've been working with 2 other facilities who are implementing this program. And I had conversations with a bunch of others about implementing their own version. I don't know how I'm going to get any research out of any of these. We didn't collect the data, but I don't even know how to write it up. They've got some stuff. The other facilities are doing stuff, and if I had money, I could evaluate. But I don't have any money, and when they say, "Do you want to do this?" they want to usually do it now. They don't want to wait 6 months or 12 months for me to put in a partnership grant or a linkage grant. So anyway, this is going. And finally, I'd just like to talk about stigma, because I think that stigma is the elephant in the room often, in that we go, oh, well, it doesn't happen because of stigma. But then no one actually does anything about the stigma. It's just there. And I think that a lot of you coming from the mental health background have seen how in Australia and in other places we've worked really actively to challenge mental health stigma, and that's what we need to do in dementia. So advocacy organisations are saying that stigma is a problem. Social isolation is one of the biggest problems about living with dementia in the community, and Dementia Australia is trying stuff like education, like the Dementia Friends program. I think that the idea that education somehow is going to fix stigma is flawed, and we know that from mental health stuff. Because knowledge and feelings don't always align. And I think that that there's some really fundamental human stuff, and there's no science behind this, it's just what I think, around why we see people with dementia the way we see them. So, how would you feel about eating these? Like we go, ugh! And I can tell you they're food and they're safe and they're food grade, but you'd still go, ugh! And I think that's where we're at with dementia. So this study showed that when you ask people about dementia versus older adults, that people with dementia are perceived as possessing less humanness characteristics. So they're seen as less human than older adults. That's kind of terrifying, but if you look at how we treat people with dementia, maybe that's true. So we live in a very cognitive society, right? I was taught this. We all know this. Everyone knows this, right? I think, therefore I am. Cogito ergo sum. It's kind of that's what makes us not dolphins. Well, I mean, it doesn't really, but that's what we think, right? That's what makes us different from beasts, right? That we can think. And then we have self-identity. And, you know, dogs don't have self-identity. I don't know if that's true, but that's the belief. So I guess the question then is, if I don't think, then am I not? Or am I lesser? And I think that's a really fundamental thing. I was having a conversation with Bobby Redmond, who lives with dementia. She's a psychologist. She's an amazing woman. And she says that she doesn't know what her identity will be when her dementia gets worse. It's like an existential question that she's grappling with. She goes, who am I when I can't remember things? And I guess this other belief that, like, we are nothing more than the sum of our memories. What if I don't remember? Am I not me then? Am I not that person? And lots of carers will say to me, well, he's not the man that I married. That's not my mother anymore. So somehow, if you're not who they were or not a person, then who are they? Are they still a human, a person? And that's, like, I think some of this difficulty is where the stigma comes from. I don't have an answer for you. I just have my own grapples. So Kate Swaffer has forced me to challenge my unconscious bias, and I'm going to challenge yours. So just go with me. How would you feel if your taxi driver had dementia? I'd be scared. I'd be like, oh, I don't need to get... Would you let someone with dementia babysit your young children? I have a very funny answer to this because I'm like, well, I'd let Kate babysit my kids because I know her. And actually, I let Bobby babysit my kids, you know, who works in Dementia Lifestyle Coach, because I know her. But if someone just applied for a job and someone said, oh, they've got dementia, I would not let them babysit my kids. I have stigma. How would you feel about employing someone with dementia? What if one NRA came to you and you discovered they had severe, they had cognitive impairment? Would you hire them? Would you have them on your board of advisors? If someone with dementia said, I want to come and work with you as a volunteer, would you give them a job? It's pretty challenging. And I guess then, how would you feel if you were locked up because you had trouble with problem solving? Because that's what we do. So this is a report from the UN about deprivation of liberty and ending deprivation of liberty on the basis of disability. That's what we do to people with dementia. Actually, we do it to all kinds of older people without dementia. My father-in-law, he didn't have dementia. He had cancer, and he had to go into a home because we couldn't look after him, and he was not allowed to go out by himself. Why not? When he was at home, he could go out by himself, whether it was safe or not. Why couldn't he go out by himself? But he couldn't. We had to sign him out. So my vision then, I guess, because of our aspirations, is that people with dementia have universal access to rehab to support their daily function, psychological function, physical function, social function. And that access is available irrespective of the type of dementia, stage of dementia, where they live, whether they live at home or in aged care or some other type of housing, how much money they have and whether they have a carer or not. I don't have the answer to this, but that's like the tranche of work that we're trying to do now. I'm going to go. And I guess we're just starting to think about what a model of care might look like. And I know that that's stuff that you guys are interested in here as well. So a lot of the post-diagnostic pilots that have happened have used a link worker, navigator worker model. I don't know if that's right because it doesn't make more services that don't exist. It just accesses people to services that are there. Should it be a specialist team? Should it be shared care? Should it be through GPs using chronic disease management systems that we already have in Australia? Or can we integrate it in some other way? That's the things that we're thinking about. I have no solutions for these, but maybe we'll write something about it next year. The last thing to say, I guess, is that we're not rational. Humans are not rational, even though I'd like to think I am. And that as we think about practice change and culture change and, changing systems, that I've realised that, well, there's conscious drivers, rewards and punishments, that there's a lot of unconscious drivers as well that we need to think about, like habit. We just do it because this is the way I was taught, this is the way I do it. I have peer pressure to do it a certain way, like drink, so I don't drink much, but I feel peer pressure to drink. And that social media is a driver of change, #MeToo now, and that we should be thinking about how we use that as well. And now I'll take feedback and questions, but I'll take feedback as well.